we're going to talk about sciatica. So when sciatica is when you have pain in your butt, maybe down the back of your leg, maybe into your calf, somewhere along that nerve root line. Again, that particular nerve root line is L5S1. So we know that there's some irritation further up, somewhere along that nerve root that's irritating it. Sometimes, actually, in myself and in many of my patients, sometimes we feel it in the front of our thigh. Sometimes it's in the front of the shin. Again, that's more the L4, L5 nerve root. So as we talk about nerve roots, here's your vertebrae, which I don't have the skeleton, but I think my hands show you quite well. So this is a vertebral body in the transverse processes. Vertebrae, 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 vertebrae. So as those vertebrae stack throughout your spine, sitting on your sacrum, then into the pelvic bowl, into the hips. So out in between each vertebrae is a nerve root that comes out. So as we talk about sciatica, it's a nerve root irritation. So what we need to determine is what is irritating the nerve root and why. What else is contributing to that structure that's irritating the nerve root? And again, how do we peel back? How do we address what's irritating the nerve root? And again, how do we address that? So sometimes there is a disc bulge. And in my practice, I've noticed like when there is a very hot swollen disc, we absolutely need intervention. Like we need to bring in a steroid pack. And I've had some patients where they absolutely have needed the nip and tuck, where they needed to have the disc nipped, cleaned up to get tension off the nerve root. But for most of us, and me included, there's mechanical inefficiencies that are creating irritation, pressure on that nerve root. And what I see so commonly, and again, in the clinic, we discern your symptoms. You know, is it worse with walking? Is it worse with sitting? Again, is it a flexion or an extension thing? But what I see so much in the clinic, here's our vertebral bodies, is if there is lack of mobility somewhere else. So very common. We have, as we go into the pelvis, we've got the uterus, ovaries, the intestines. If there's ever been any surgery, any GI surgeries, any hysterectomy, history of heavy periods, history of trouble with the uterus or the ovaries, fibroids, whatnot. Diverticulitis has come up. I've seen that. Appendectomies, I've seen. So as we look at the front of the back, again, the intestines sit on the front of the back. Uterus sits on the front of the back. Bladder sits on the front of the back. So if there's ever been any trouble with any of those structures, that could absolutely create compensatory strategies when you walk, when you move, that strain the lumbar spine. And again, as forces are distributed through the body, if there's an area of the body that does not move well, the body is brilliant. It will find another area to help you move. Again, what happens is too much force is applied towards the lumbar spine. So as too much force is applied over time, one time is fine. But as you walk, 1 step, 2 step, 3 step, 4 step, 1,000, 12,000 steps, you're getting your steps in, right? Here's all of these forces, and here's your nerve root coming out. So here's this vertebrae that maybe has a little shift, a little shear, a little forward pressure, puts just a little bit of irritation on that nerve root. So when you walk, right, every time you walk, pressure, nerve root is irritated. So again, this is just one scenario of the patients that I see in my clinic with sciatica. So where we go with that, we tease out, okay, let's really dive into your symptoms. Where does it hurt you most, less? Has anything showed up on an MRI that may or may not change what we do? It very likely does not change what we do because, again, our work is in mechanics. We look to restore efficient mechanics throughout the pelvis, the legs, the body. Sometimes, I was telling a friend of mine who has not been playing tennis because she has sciatica and she's going to pain management, which sometimes pain management is really helpful, but unfortunately, our work is missed. The mechanical restoration of efficient mechanics is often missed. And then we jump right into pain management, which very often pain management is a Band-Aid. So again, pain management is how do we get the pain to stop, but it's not addressing the why. It's not addressing why there's irritation on the nerve root, and that is our job to tease out. How do you walk? How do you move? What's happened throughout your lifetime? What injuries and traumas have you had that have changed the mechanical landscape of your body, that have created increased strain patterns on your disc, lumbar spine, and or nerve? So that is our job, to tease all of that out. So we look at you from head to toe. I want to add as well, sometimes in some of my patients, because again, I see patients who've had surgery. They've had laminectomies, they've had discectomies. And again, these surgeries have addressed degeneration or damage. But what these surgeries have not addressed are the mechanics that contributed to the damage over time. So these people have surgeries, but we're not addressing the whys. We've addressed the what, but not addressed the why. So again, still it is critical, these people who go in for surgeries or injections, and they're not getting results because again, the why has not been addressed. So in some of these patients where again, they've had maybe really great treatment of the pelvis, of the lumbar spine, sometimes we will find even in the cranium. So the dura is the covering of the brain and the spinal cord. And again, if you've ever had an injury or there's been head trauma or there's some major jaw work, sometimes the tension in the cranium can absolutely create a tension, a strain pattern throughout the entire system, because we are created as an entirety. The dura, covering of brain and spinal cord into your nerves, it is one entire system. So think of it like a wetsuit. You pull at one end, the strain pattern goes all the way down. So I've had a couple patients where the primary strain pull was actually in the cranium from an old head trauma, multiple head traumas, football players. So we've needed to get tension off the cranium, off the dura, which absolutely took some tension off the lumbar spine. We still needed to go in and work the mechanics of the tailbone and sacrum, pelvis, lumbar spine. Absolutely. We need to retrain the pelvis, how to move well, retrain the stability of the pelvis, hips, lower lumbar spine. But again, we look at the whys, we look at the big picture as to, here's a symptom. Okay, who are the players? What's contributing to that? Because again, just addressing a symptom is not addressing the whys, and maybe that symptom calms down, but it will come back later, or it will show up as something else. So address efficient mechanics. We just continue to problem solve the whys, and we have a great time doing it. We get great success, and we can't wait to help you.